All right, welcome everyone. In this high-yield review, we're going to break down the latest clinical practice guidelines for acute otitis media. Let's get right into it. So, to really frame why this is so important, let's start with a question. What do you think is the single most common diagnosis that leads to a child in the U.S. getting an antibiotic? The answer, of course, is acute otitis media. We're talking about over 10 million prescriptions every year, which means mastering this topic is absolutely essential, whether you're in pediatrics or primary care. Okay, let's dive into Module 1. Here, we're going to nail down the precise definition of AOM and review the key bacteria causing it. This foundation is crucial for everything that follows in diagnosis and management. The definition we're going to use comes straight from the American Academy of Pediatrics, and this is a critical point. AOM is not just a red eardrum. It's a very specific clinical triad, which we're about to detail. And here is that essential triad. To make a definitive AOM diagnosis, you've got to have all three of these components. First, there must be clear evidence of a middle ear effusion, or MEE. Second, you have to see signs of acute middle ear inflammation. And third, the symptoms must have started acutely, meaning within the last 48 hours. All three have to be there. You know, understanding the bugs is key to picking the right drugs. Right now, the dominant player is non-typable Haemophilus influenzae, causing up to 60% of cases. Streptococcus pneumoniae is still a major cause, followed by Marxella catarrhalis. These are the bad guys our antibiotic strategies are built to fight. All right, Module 2, the clinical diagnosis. Now, I really want to hammer this point home. AOM is a clinical diagnosis. There's no gold standard lab tests, no imaging that gives you the answer. The entire diagnosis rests on what you find during your physical exam. This table really breaks down the most valuable things to look for. Notice the bulging tympanic membrane. It has an incredibly high sensitivity, 97%. But for your board exams, the single most accurate physical finding is tympanic membrane hypomobility on pneumatic otoscopy. With 94% sensitivity and up to 90% specificity, if you see that, you should be highly suspicious of AOM. So, here's a massive, high-yield takeaway for your exam. An isolated red eardrum, just erythema, does not predict AOM. A kid's eardrum can look red just from crying or from a simple cold. A definitive diagnosis requires objective proof of that middle ear effusion, like a bulging, opaque, or most reliably, a hypomobile tympanic membrane. So you've confidently made the diagnosis. Now you've reached the central decision point, and that's what we're tackling in Module 3. Do you start antibiotics right away, or is it okay to observe for a bit? This question is really at the heart of antibiotic stewardship when it comes to AOM. The clinical practice guidelines are very, very specific about the criteria that absolutely require you to start treatment immediately. Okay, so you must start antibiotics right away for any patient with severe signs or symptoms. And the guidelines define severe for us. That means moderate to severe ear pain, pain that's lasted for more than 48 hours, or a temperature of 39 degrees Celsius or higher. It's also mandatory for any child under 2 with bilateral AOM and for any patient with otorrhea, that's drainage from the ear, which tells you the eardrum has perforated. On the flip side, for children over the age of 2 who have a one-sided, non-severe ear infection, watchful waiting is the recommended standard of care. This approach means giving them good pain control and making sure there's a solid plan to follow up in 48 to 72 hours. This is based on strong evidence that a lot of these cases get better all on their own. Moving on to Module 4. Now, for the group of patients who do meet the criteria for antibiotics, what's the recommended first-line agent and how exactly should we be dosing it? The guideline recommendation here is totally unambiguous. High-dose amoxicillin is the first-line therapy for acute otitis media, as long as the patient doesn't have a contraindication. Now, while you might see age-based dosing schedules like this one, the key high-yield recommendation from the American guidelines is to use weight-based dosing. Specifically, a high dose of 90 milligrams per kilogram per day, usually split into 2 doses. Why so high? Well, that dose is critical to get enough drug into the middle ear to kill off any potentially drug-resistant Streptococcus pneumonia. Of course, we always have to have a plan for patients with a documented penicillin allergy. The guidelines give us very specific alternatives. For a true type I, IgE-mediated penicillin allergy, your best alternatives are going to be macrolides like clarithromycin, or you could use clindamycin. It's also worth noting that erythromycin is often the preferred agent during pregnancy. For less severe non-type I reactions, certain cephalosporins might be an option.
And that brings us to our final content module, Module 5, Treatment Failure. What's the right move when that first-line therapy doesn't resolve the infection?
Well, first, we need to be very precise with our language. What are the objective criteria we use to determine that the initial antibiotic has actually failed? The most important point here is the timeline. Treatment failure is defined as a lack of clinical improvement in signs or symptoms within 48 to 72 hours of starting that antibiotic. It's really essential to give the drug that window to work before you escalate care. So if a patient on amoxicillin isn't getting any better, the most likely reason is that they have a beta-lactamase-producing organism. Because of that, the logical next step is to add a beta-lactamase inhibitor. This expands our coverage to hit those resistant strains of H. influenzae and M. catarrhalis. This table really serves as a great summary of the whole treatment algorithm. For standard oral therapy, you start with high-dose amoxicillin. If that fails, you escalate to amoxicillin clavulanate. For any patient who can't tolerate oral meds, intramuscular or IV ceftriaxone is the drug of choice. And that last row walks you through the pathway for patients with a severe penicillin allergy. It's just as important to know which therapies to avoid. The guidelines are very firm that there is no evidence to support using antihistamines, decongestants, or corticosteroids, whether they're systemic or intranasal, for the routine management of AOM. They offer no clinical benefit, and they are not recommended. Okay, we've covered the core principles. Let's wrap this up by summarizing the absolute highest yield takeaways for your board review and then pose one final thought for you to consider. Let's do a quick rapid-fire review. 1. The diagnosis requires the complete triad: effusion, inflammation, and acute onset. 2. The most reliable physical signs are a bulging or a hypomobile tympanic membrane. 3. Observation is the standard of care for older kids with mild, one-sided disease. 4. First-line therapy is high-dose amoxicillin. And 5, if there's no improvement after 48 to 72 hours, you switch to amoxicillin clavulanate. And this leads us to our final thought. The management of AOM is this constant, delicate balance between resolving one patient's infection and the critical public health need for antibiotic stewardship. As bacterial resistance patterns keep shifting, future guidelines are going to have to constantly recalibrate this essential balance. Thank you for joining this review.